right now, where we're most commonly using our cisplatin-based chemotherapies are in patients either in the neoadjuvant setting, so patients that present to us with muscle-invasive disease, many of which may have T3, clinically T3, T4 lesions, and we'll treat those patients with cisplatin-based chemotherapy with the hopes that they're still potentially resectable, or perhaps they have more, appears to be organ-confined muscle-invasive disease, and we'll be treating them more for a complete response, pathologic complete response rate. What we see in that population is a mix. We'll see patients that have about, on average, somewhere around 20–30% of patients get a pathologic complete response. Majority of patients will have residual disease. For many of those patients that have really locally advanced disease or nodal disease, the complete response rates are low. Really what we're doing there is essentially a debulking. Follow-up, many of those patients are going to relapse within the first year, certainly within the first 2 years following chemotherapy. So if they're going to relapse, that's when we see our relapses. On average, when we're treating patients in the metastatic setting with, say, frontline cisplatin-based chemotherapy, we see response rates somewhere around 50%. Those are usually partial responses, but occasionally we can see complete responses, particularly in patients with lung-only or lymph node-only disease. For patients that are getting a partial response, their time to progression following the chemotherapy is generally short, about 4 to 6 months. So for me, when I'm treating somebody with platinum-based chemotherapy, if it's in the neoadjuvant setting, we're quickly moving on to surgery. There really isn't time to reassess. It's typically 4 cycles of chemo and then on to surgery. For patients that I'm treating metastatic disease, I'm assessing after about 3 cycles of therapy, about half of our patients are showing some level of response. Another, maybe quarter of patients show stable disease. About 25% of patients will be blasting through that. And that's the group of patients we want to pick up early and get on to checkpoint inhibitors. For those that are stable or responding, we're able to complete maybe 6 cycles of chemotherapy, but their time to relapse following that is going to be short. So that's the group of patients we're monitoring closely for. Lastly, there is a group of patients that get a complete response to chemotherapy or maybe a really good partial response that will last a year or more. Historically, those are patients that we can re-challenge with platinum chemotherapy and see response to again. So, I don't want to forget about that population. Platinum's still a good agent. I don't want to say everything is checkpoints. There's a role for sure for cisplatin-based chemotherapy, but it has to be taken into context. The majority, 75% of these patients, are going to either have transient responses or no response at all, and we've got to be prepared to make that quick switch to immunotherapy. When I'm using the checkpoint inhibitors, PD-1, PD-L1 inhibitors in that setting, I'm going to be a little bit more flexible in making a thumbs up or thumbs down decision based upon a single time point and scan, particularly if there's not clinical progression associated with it, and knowing that I chose that checkpoint inhibitor as a frontline therapy over chemotherapy for a reason. Either they're platinum ineligible or I don't feel they're very good candidates for carboplatin-based chemotherapy. So my threshold for continuing through a mixed response is pretty high. But if patients have real clinical progression, if there's clear visceral progression going on or new sites of disease, those are the patients we do want to switch. There are a number of clinical trials going on now looking at PD-1, PD-L1 refractory patients in bladder cancer, and I think we are going to make some progress building off of this monotherapy, immunotherapy, baseline for many of these patients. So therein lies the hope.